Hello guys, welcome back to the channel. This is Side Dental Vlogs and today's video is about just about 1 mm. Yes, so recently I have uploaded a picture in YouTube and in which you can see there is some infection in the palatal root of the upper first molar. So this is what happened actually. I did one root canal of one patient, three root canals basically, and I was supposed to place a bridge. I even placed the bridge and it was going on quite well for 6 months, but after that the patient started complaining of some heaviness around the maxillary area, and I thought maybe there is some high point in the tooth, or there is some high point in the restoration what I have given. So I started to reduce it and try to trim it and all those things what we do after we place a crown. So this was not the case, and it didn't stop. So I wrote for one CBCT for the patient, and after doing the CBCT, astonishingly, I came to know that there is some infection in the maxillary sinus, and initially I was like perplexed. Like when I saw the canal, it was only 1 mm, 0.5 to 1 mm short of the, and I had done the root canal in 3 to 4 sittings. I had given proper irrigation, everything. So even what mistake I had done, what was the mistake which was done? So the proper apical gauging was not done. That means in the parallel canal, I had put 6% 20 GP, which should have been around 6% 40. The parallel canal was quite wide for the patient. So what happened? There was a formation of biofilm in the canal. So basically, when what I did after that, recalled the patient. I made a hole in the crown of the upper six or seven. I don't remember, six, I think. Yes. Then I only took out the GP from the palatal canal, and to my astonishment, I could see some pus is coming out, which was slightly green in color. So if it is green in color pus, that means there is a pseudomonas infection, which is usually present in the maxillary sinus. So what was happening inside? Actually, there was infection in the palatal canal of the upper molar teeth. From there, it perforated into the maxillary sinus. There was maxillary fullness, and the entire maxillary sinus got fluid filled. So after that, we took out all the pus, we drained all the pus, and I gave ENP, intracanal calcium hydroxide, for 1 month, 2 months, 3 months, and we kept on change like the dressing. So after that, I decided to do the entire RCT, and I removed the entire bridge of the patient. And thanks to the patient, she was very cooperative, because I had taken many sittings for the root canal, and just because of one small 1 mm, it can lead to so much of harassment both for the patient as well as for the doctor. And so now it is sorted, and after placing the calcium hydroxide in the canal, now the infection has reduced a lot. So what is my assessment why this happened actually? So while I was doing the initial root canal, so the maxillary tuberosity of the patient was coming in between, and I was not able to get the clear image of the palatal canal. So sometimes we often uh, miss out on the apical gauging. We don't see take too many x-rays. So my suggestion is take many x-rays in different angulations, so that you can obturate the canal properly. And after doing the root canal, you have to wait for few days. If even if you're giving a bridge, just give a temporary bridge and tell the patient to wait for a month, so that there won't be any symptoms, and after that you can give the bridge. So sometimes we should not ignore the symptoms of the patient, because I ignored the symptoms for 1 month and it increased. So we could have just intervened in the very beginning, and we could have done the root canal re-RCT. So we waited for 1 month to see if the pain subsides, but it didn't happen. So we have to remove the bridge, and then we started with the RCT again. So for what we should do is we should give proper antibiotics. We should take the pus culture and send it for culture. It's a very cheap test you can do, and you can write specific antibiotics. So we wrote cefixime third generation cephalosporins for this patient, and it reduced. After that, we have to check for the diabetes status of the patient. That all things we did, it was normal. Patient was diabetic, but it was normal. And we have to be very careful while we are doing the RCTs of the 6 and 7s, because 70% of the people are having MB2 canals, which we usually miss. So the MB2 canals also a culprit. So if you are having any doubts about the canal system, you can always write for a CBCT. It's hardly costing 600 rupees for one tooth or 500 rupees, which can the patient can afford. If the even if the patient is not able to afford, I think you should request the CBCT center to do it for a little bit less, because if you are sending regularly, they do it generally. So this was my case, and now the case has been resolved. So just wanted to discuss this case with you all, and hope you have a better practice. And good evening to everyone. So if you like this video, please do share, subscribe, and you can watch the images in my Instagram sai_dental, where I'll be uploading it, and you can also see the image in my community where I have posted the image in the YouTube. You can see the X-ray of the particular tooth. I will also share a video in Instagram, sai_dental. Till then, take care. Bye bye. Love you all.